Ragazzini, ragazzini, are you there?
Azzi.
Are you there? Are you there?
We're always here.
Ragazzi, we
Ante.
spent a marvelous few days all together, all the team, except Sebbi. Poor Sebbi was not with us in Athens. Che bello. There was the Melanoma Congress. Come on, this is an impressive conference. It was indeed
It
impressive.
was. It really was. For me, I think it was the best conference I've been. And I mean, I'm biased. It was not.
You're
Uh,
biased. You're biased.
but I really enjoyed it.
Yeah. Great, 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 great. Emilio,
Sì,
Emiliuccio, are you okay?
almost.
Almost. Nisa, you know that these few days I got very incredible news about Nisa. So
What's that?
the real age of Nisa, it's something you cannot believe. I will not tell you. I will not tell you.
This is
But
yeah.
she's not 35 like I supposed she was.
She's 34.
Don't tell me.
The age is relative. The age is
It's
relative.
a secret.
It's a secret. It's a secret. Yeah.
Anyhow, based on my new age classification, we don't care anymore about the age.
No.
Yeah.
Correct. We have many people. Hello, guys. How are you? How are you everywhere? Hungary, Estonia, Poland, UK, Taurasi, Buenos Aires, Romania, Turkey, Riga, Poland, Salerno, Galles, Berlin, Romania, France, Jerusalem, Germany, Dakar, Georgia, Beirut, Poland, Uzbekistan, Tunisia, Azerbaijan, Greece, Italy, Poland, Venezia, Poland, Milano, Liverpool, Belarus, Lecce, Bratislava, Canada, Torino, Armenia, Bulgaria, wow, Ecuador, wow,
Ecuador.
Ecuador, Moscow, Beirut again.
Where is the map, Gary? Okay, Gary, we will not do
Where's
it.
the
I promise we'll do it once again.
Yes, you must do it. Yeah.
But my goal would be to have at least one attendee from Greenland.
Greenland, yeah, Greenland.
Have you seen all the memes?
Maybe one day Trump.
Yeah, yes.
Have you seen all the memes that came out after Trump's tariffs with the penguins from the McDonald Islands being flipping the finger to Donald Trump?
Yeah.
Oh, you know that we should not say these things publicly, because if you want to go to the US, they might not allow us to enter.
I
Come
just
on.
stated, did you see the memes? I said nothing more. I
Yeah.
didn't take any position. This is a neutral
Oh,
statement.
listen, authorities, Konstantinos only is saying this stuff. not us.
No, but let me tell you a story about politics and other things. We were in the stadium for a soccer game, Napoli against Bologna, with my son. And there was a guy in our space with a flag in the Naples area with a flag of Che Guevara. Okay.
Right.
There was another Neapolitan guy just quite far away who was shouting against this guy with the flag of Che Guevara, and he was saying very bad words, and he declared something. We are not involved in politics because we care only
For the
of
team.
footballs, yes, of the soccer. And this is something very, very interesting. Yeah. Okay.
Yeah, but the thing, well, it's a very big conversation, the one that we need wine and time to discuss, because a lot of teams declare no politica, but then they're swinged by their owners towards politics.
Yeah.
It's a very big discussion.
Of course. But it's not the case today, because today we speak about what, Sebi? We speak about Difficult melanomas. How many melanomas are difficult in your view? Less
To diagnose women.
difficult to diagnose, of course. Yeah. Less than 10%, 10 to 30%, more than 30%. Let's see. Let's see. Of course, everybody would say less than 10%, but it's, yeah, I suppose the most reasonable choice is 10 to 30. Yeah. You agree? You agree?
Um,
Most reasonable?
It depends. It
it,
depends.
it depends. It depends.
It's all a problem of dermoscopy, because if we didn't have dermoscopy, then all melanomas would eventually grow and that would be easy to diagnose.
Yeah, exactly.
Yeah. Okay, so this is, as we said, right, Constantino and Isa, this is an episode of the Happy Hour, which is not so happy. We speak about unhappy things. So it's unhappy hour.
The unhappy hour.
Unhappy hour. Yeah.
Yeah.
Anyway, what should we do? We have to, from time to time, be a little bit unhappy.
Take a poll. Which is the most depressive topic that we could speak related, of course, to dermoscopy?
Yeah. Maybe Sebi could set up a poll asking free text, what is the most depressive stuff in our area? Yeah, good. Okay, who starts?
Ladies first.
Ladies first.
Okay.
Bye, Nisa.
Yeah.
So we are presenting a collection of difficult melanomas, right? Nothing more than this. And the aim to share difficult melanomas is also to share the ways we were able to catch these melanomas. Okay, because a real difficult melanoma is the one that I don't know it's difficult because I left it. I left the patient go. You know what I mean? So the real difficult we don't know, but the difficult melanomas we were able to catch. Then we have to understand how to catch them. Good.
Yeah. And I'm going to start with Nevoid melanoma. Actually, this is sometimes very difficult for us as a dermatologist, but I think it's also very difficult to diagnose sometimes for the pathologist as well, because histopathological findings sometimes really look like a nevus.
Yes.
This is a rare subtype of melanoma and mimics benign melanocytic nevus, and it was first reported in 1980s, and then the specimens are re-examined, and these same findings were again described in 1995 after completing a 20 sample case survey, and concluded that this is a new variant of melanoma, and they call it as Nevoid melanoma. Actually, as I say, it's really rare and accounts for approximately 0.5 to 3 of all melanomas, and predominantly located on the extremities and sometimes chest. And this is interesting because the association with benign nevus is almost 45% of all cases. Clinically, the melanoma looks like a dome-shaped papule or nodule with smooth borders, but also can be verrucous or plaque-like. And the color is often monochromatic, but sometimes can be bichromatic. Histopathologically, the lesion is a symmetric lesion, and melanocytes resemble really nevus cells, appearance of relative maturation of dermal melanocytes with limited junctional melanocytic component, and that's why this is often confused with benign nevus. And if we look at under higher power, we can see that atypical melanocytes present with pleomorphism and nuclear atypia, and mitosis generally found in the deeper portions of the tumor. This is very important for nevoid melanoma. Actually, histopathologically, there's two subtypes of this melanoma, papillomatous and maturing nevoid melanoma. this presents with clinically and histopathologically some differences, which I'm not going to talk about today. Histopathologically, we need sometimes fluorescent in situ hybridization because there are 3 studies reported that successful differentiation of nevoid melanoma from nevus, especially mitotically active nevus, can be done with this method because the gains in 6P and losses in 9P aberrations are generally observed in this subtype of melanoma, but never in mitotically active nevus. Of course, early diagnosis is very important, but since the lesion looks like a nevus and histopathologically as well, generally breast of thickness is thicker in these cases when we make the diagnosis, which is generally bigger than 1.5 millimeter in these cases. And I find something interesting in the literature. We know there's a immunotherapy called erlotinib, and this is generally given for metastatic lung cancer. And under this therapy, there are some cases of occurrence of eruptive nevi. And in one patient, there is also a nevoid melanoma developed after this eruptive nevi. And the authors think about that, like vemurafenib therapy, these drugs can induce the activation of MAP kinase pathway and melanoma can develop. So we can be careful in patients under erlotinib therapy. And I just want to show you 2 cases from my practice. This is the arm of a lady, and this is a lesion. It was a dome-shaped nodular lesion, and also we can see the flat part at the periphery. Here is a dermatoscopy. It looks a bit chaotic, but the nodular part is just blue, structureless. And here is the histopathological appearance. It's really very symmetric in appearance. And here is the close-up. And here are the atypical melanocytes. And there are some sort of maturation, but here we can see mitosis in the deeper part of the tumor. And this was a nevoid melanoma with a breast of thickness of 1.8 millimeter. Another case with papillomatous and varicose appearance. Especially the authors detected that the polymorphic vessels over the surface of papillomatous projections is very important in this melanoma subtype. And here you can see the polymorphic vessels, and the rest looks like a dermal nevus, but we have some white reticular lines. And this is another nevoid melanoma with a breast of thickness of 2.2 millimeter. And the lesion just developed in 8 weeks. This is a very rapid development, and the patient was a very close friend of mine. Luckily, she is still surviving without any metastasis. And I would like to ask you a question. And this is a lesion, and this is my cousin again. And she suddenly sent me a WhatsApp photo. Nisa, there's a lesion on my trunk, on my flank, and I think this is there for the last 1 year, and it's growing. And I was shocked when I saw the lesion. And here is a close-up.
Ah,
And let's have a look at the dermatoscopy.
wow, 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 wow.
In 1 year, and she is 65 years old.
But
What do you think?
I mean, of course, here there is a differential diagnosis between seborrheic keratosis and melanoma.
Well, yes.
Yeah.
Dermoscopically, it's
Yeah.
extremely ugly.
Extremely
ugly. And there are some white reticular lines, and we have dotted vessels, and we have gray color. And how about this part?
And white shiny lines also.
Oh, it's a BCC.
And some BCC-like structures
My
also.
God, yeah.
Yeah.
Oh, it's a collision.
Yeah. So if this is a BCC, what can it be? Which type? Let's go back to clinical.
Pincus.
Pincus clinically. Pincus clinically.
Yeah.
Pincus.
Yeah. Pincus. And
Yeah.
here is the histopathology, which is a great relief for me. This was a pincus subtype of basal cell carcinoma. So all the family was very happy because
Good for the cousin.
really at first consider about melanoma, but there was the thinking about that since we have radial lines converging and there's a possibility of pincus, and histopathology was very good for all the family, and that's it.
Brava. Of course, fortunately, the two cases of nevoid melanoma you showed were not so difficult because they were very ugly from a clinical and also dermoscopic point of view. But sometimes the problem is a little bit, it was present in the second case when you see these papillomatous melanomas, melanomas showing a papillomatous surface.
Yeah.
Why also the pathologists think that this could be a benign lesion because of the papillomatous morphology. Yeah.
There is a question, how is the palpation of nevoid melanoma? Is it soft like the dermal nevus is?
Like dermal nevus, yeah.
If it's
Well,
soft, on palpation.
Yeah, a papillomatous melanoma is
Papillomatous.
papillomatous melanoma is soft because the
Yeah.
papillomatous architecture, it's soft. Yeah.
But not all nevoid melanomas are papillomatous and soft, but it could be. It could be. Yeah. Nevoid melanoma is nevoid for the pathologist or for the dermatologist? That's a good question. There was a study, we do have the answer in this question, Giuseppe. A subcategory of them are nevoid also for us, meaning that morphologically they look like dermal nevi, in fact. And these are the most difficult to diagnose subtype of nevoid melanomas, of course. But there is another subgroup which clinically and dermatoscopically looks like a classic melanoma, so multi-component pattern, ugly lesions, and histologically they are nevoid melanomas, no problem with them. And there is a third subcategory which are non-pigmented nevoid melanomas, which fall into the morphology category of amelanotic melanoma. So they share, they have the features of an amelanotic melanoma, which are subtle features, of course. But the worst category, of course, is the one that looks like a nevus also clinically and dermatoscopically. I don't think there is any other question for the moment. So Nisa, your point was that, in your opinion, the most difficult melanoma to diagnose is nevoid melanoma, correct?
So I think it is because of the breadth of thickness in the literature. They are generally missed, and in the follow-ups, when the lesion is changing, the lesions are excised and observed that it's a nevoid melanoma. It's really very challenging for the point of pathologist as well.
Yeah.
There may be a lot of overlooked or nevoid melanomas.
Yeah.
Absolutely.
Wonderful.
Very good.
Costantino.
But if that's okay, I would like to go last because I have a different message.
Okay.
I want to finish with a happy note.
Okay, good. Who's next?
You.
Me. Okay. So, in my estimation, so what is the definition of difficult melanoma? Difficult melanoma is the one which is mimicking a variety of different benign lesions. For example, in this particular case, this is for me a lentigo slash seborrheic keratosis, clinically, okay? So this is, of course, an easy differential diagnosis because even if it's a melanoma, it's a superficial melanoma, right? So nothing bad can happen in a scenario like this one when the differential is between lentigo, solar lentigo versus let's say melanoma in situ or lentiginous melanoma. Okay, here
I agree. I agree. This is really very difficult melanoma to diagnose. Yeah.
Yes, exactly. So in my view, this is extremely difficult. But in especially in Athens, we spoke about the pretest probability. No, what is the pretest probability? Based on the patient age, you know that if you see a child, your pretest probability that you are confronting with a melanoma is very low. How many melanomas in children did we see? Very few, or almost none. So when we see an ugly lesion in a child, most probably it will be still a benign lesion, while the pretest probability in an elderly person is increasing. So we have to be very careful with elderly people because the chance that what we see is a melanoma is much higher. Okay, so here there is a differential, solar lentigo versus melanoma. In this particular context, in my view, there is a sign which is speaking most in favor of melanoma than for solar lentigo. What is your opinion here? What is the sign we can see here?
Pigmentation lacking skin creases, angulated lines.
You mean
Angulated lines, exactly. I call them rhomboidal structures. Okay, so this was a melanoma in situ with these rhomboidal structures. You see these lines, especially in the center of the lesion, where you see these angulated lines, and this is very typical for lentiginous melanoma, for lentigo maligna appearing outside the face, Okay, but this is my view. Very, I mean, nothing bad can happen. In my view, the most difficult are the differential diagnosis between blue nevus and melanoma, seborrheic keratosis and melanoma, hemangioma and melanoma. I don't know, basal cell carcinoma and melanoma. Sometimes we also have this problem. So here, this is a 59-year-old lady. Lesion appeared in the last few years. Okay, this is the arm, and this is what we can see dermoscopically.
No, come on! Don't tell us that this is.
Come
Please.
on.
This
Which
is
No.
is a lesion which is morphologically looking like a blue nevus.
Yes, is a blue nevus. Come on.
Exactly, and this is a blue nevus. Yeah.
Okay.
Okay.
Okay. Then okay.
The blue nevus, yeah. But I mean, whenever we see a blue nevus, we have to ask ourselves: is this a blue nevus or is this a nodular melanoma? Of course, pre-test probability. If we see a blue nevus in a 25-year-old girl, most probably this is a blue nevus, while this is 59. So we have to carefully, analyze the features. Nothing to be worried about here. It's a small lesion. It's bluish, no black, nothing more. This is a blue nevus, independently from the fact that this lesion appeared in the last few years. Who cares? Who cares? Okay, because blue nevi can appear whenever they like. Okay, but I show you now this lesion is a man, 48. The lesion is located on the leg. Okay. Clinically, by the way, there is almost a papillomatous surface. You see? Papillomatous.
Nevoid.
Yeah, dermoscopically, it's like this. It's a bluish lesion. Do you feel confident completely that this is a blue nevus?
How about non-polarized dermatoscopy?
Yes, this is non-polarized. No, this is polarized. This is non-polarized.
This is polarized.
Polarized.
Tiny white lines.
Yeah, you see?
Now I don't feel comfortable.
Oh,
Yeah,
exactly.
you're not so
Exactly.
confident here.
So,
better to excise.
Let's use our tools. Okay, we have nowadays these hybrid dermatoscopes where we can use non-polarized and polarized. Let's use both when we have doubts, especially in the case of nodular lesions, we have to really to make sure these white lines are not convincing. That's why we excised this lesion. We were not convinced that this was a blue nevus and this was a melanoma 2.4.
Very good point.
But this is a scary lesion in my view. Very scary.
Yeah.
Because look at the lesion. How symmetric is this lesion? It's
Yeah.
It is, but I have the impression that the image is not so good, JP.
No. Let me tell you, the image is fine. Maybe it's projecting not so well in Zoom, but the colors are definitely exactly what was in the reality in the face-to-face examination, both non-polarized and polarized. Yeah. Okay. Another very simple differential diagnosis is dermal nevus or small congenital dermal nevus versus melanoma. I mean, we see thousands, tons of dermal nevi, okay? But we don't have underestimate that sometimes melanoma can also mimic a dermal nevus. In my view, this is clinically definitely a dermal nevus, a small congenital nevus, okay? Because of again, a papillomatous surface. But dermoscopically, in my view, there is too much, right?
Yeah.
Yeah, it's not dermal nevus dermatoscopically, no way.
No way. I mean, it's too black. Dermal nevi are usually losing pigment. Yeah, you don't see any more black pigment in a dermal nevus, while you see a lot of black pigment here, especially at the periphery, which is also a bad sign. And look at the globules, how irregularly distributed they are. But this is again a lesion we can miss, okay? Because this is really clinically looking like a dermal nevus. And this was again a melanoma with high thickness, more than 2 millimeter. Okay?
Yeah, but this one is fine. The previous one was a bit annoying.
Yeah.
What was the subtype, JP, for this one?
In these
You
two,
remember?
they were not Nevoid melanomas. They were both melanomas. Yeah.
Melanomas.
Yes, sir.
Conventional melanomas.
Mhm.
Case to diminish the pressure. This is a young guy brought by the mother. This is also a sign. We have to. He's a 35-year-old man coming with the mother.
Is the Neapolitan mom?
Neapolitan mom.
That melanoma. We don't need to look at the dermatoscopy. Directly excise.
Okay. Wait a moment. This was August. This was very hot temperature. Yeah. And he was coming with this eruption of black stuff. Yeah. And of course, here we can think about many things. We can think about melanoma mets, no? So eruptive nevi, eruptive angiomas, melanoma metastasis, or other things. And
Scrape it off.
yeah.
Oh.
And this is what you can see demoscopically. But now you have to make a specific diagnosis, guys. What is this?
It's
Take a shower and then come back.
acrylic t-shirt.
Acrylic t-shirt is not. I'm sorry. Okay?
Oh, chair.
Bravo.
Let's say not the highest quality of leather.
Yeah, exactly. In fact, the guy is a PlayStation gamer,
Yeah.
and spending hours and hours on his chair during summertime, naked. Wonderful.
Excellent. Amazing. Emilio, you ready?
So I was thinking now that you showed this case, that maybe, at least for me, the most difficult melanomas to diagnose are the ones that deviate rules that have been established. because I mean, know pretty well that some melanomas are difficult to diagnose, and we have developed some strategies, some rules that work quite well and help us to solve the problem. And then once every now and then, it happens that you see a case that deviates the rule, and this is scaring in my view.
Yeah.
Because then you don't know how to, then you remain without any solution for the next time that it's going to happen.
Yeah.
By the way, now that you were showing this case, I just remember because it was a case of last week, and I just export it to show it to you. This is a patient of 65 years old, I think, who has metastatic melanoma under treatment. By the way, everything is okay, so he's in full remission of his mets. He never had skin mets. His mets were brain and lung, and he's doing fine under immunotherapy at this moment. So, because of the history of melanoma, he's under sequential monitoring, and then he developed this lesion, but it's not a spoken history, it's a documented history that this lesion was new, which is okay because, as we said, blue nevi might appear also late in life. But I can reassure you, I don't have now the image to show you, but I can reassure you that it was growing clearly in the follow-up examinations. Okay. So that's the clean. Of course, only one. This. Okay. Clinical and this dermoscopy. Here you can see how it looks like.
Yeah, there is some black color.
Looks like a blue nevus.
Yes, but come on, with this history and with this kind of purple coloration and the black coloration, I am very, very suspicious.
Yeah, especially when you have a documented evidence that it's growing. It's not theory.
Not only because of the fact that he is a
metastatic melanoma patient, of course. Okay, so we excised it, and you know what it was?
Blue nevus.
What?
Blue nevus.
Really? Unbelievable.
Yes.
Good.
I think this quote is great. What looks like a blue nevus, what feels like a blue nevus, is a blue nevus.
That just to compensate with the case that Jeppy showed. So very quickly, since you asked before, I just added it in the presentation. So these are the three types of nevoid melanoma. This one is not a problem. It's easy. You see that they are super ugly. They are multi-component, no issue. These are the amelanotic ones. So here, I mean, they fall into the category of amelanotic melanoma, but they don't look like intradermal nevi from a dermatoscopic point of view. Of course, there are the difficulties that always there are in a melanotic melanoma, but this is another story, and we know more or less how to deal with this. And finally, this is the most difficult category, the one that looks quite a lot like a dermal nevus. And here you can see the dermatoscopic images. For example, the ones on the right, B and D, are quite scaring. Because let's say A and C are ugly, asymmetric, but B and D are, don't you agree? They are really tough. These are images from the study, from the published study on dermoscopy of nevoid melanoma. Of course, as suggested also in the study, what is important is the fact that nevoid melanoma grows, obviously. And therefore, the history of growth or the documented evidence of growth is very, very important. But with that said, they definitely are very, very tough melanomas. But the most difficult, in my view, melanoma to diagnose, the most difficult,
there's no plastic,
is the one which is not visible.
It's the one that you cannot find.
Dermoplastic melanoma of the scalp, I think it's very
You
challenging.
cannot diagnose it, no way, because it's not visible. The only way you can diagnose this melanoma, and I think we have shown this case again, for example, this one, we were able to diagnose it. Can you imagine? Although clinically and dermatoscopically, it's virtually invisible. Only with
Nothing,
dermoscopy,
nothing.
only with dermoscopy, there are maybe 1, 2, 3 gray dots.
But this
Yeah.
was referred because of lymph node metastasis, or
Because of the metastasis,
Lymph node
which is
metastasis.
visible in the clinical
Yeah.
image. So the metastasis you see is right here. So that's the way, that's the reason why we were looking so carefully in this area, and we found this lesion that was excised, and of course still even after excision it was not clear this was the melanoma, but it was very probable because it's pathologically with the immunostains they did find some melanocytes. So the most difficult melanoma to diagnose is the one that undergoes full regression, and we know it happens. We know, we discussed a couple of times that this is an immunologic phenomenon that maybe is a good thing, but we do not have the evidence to say how often it happens and how many melanomas disappear spontaneously, and we never hear about them. We just hear about the ones like this one that metastasized, although it recurred. Then, to be honest, there are also several other types of melanomas that are difficult to diagnose, very difficult to diagnose, but for many of them, we have found solutions. Obviously, early lentigo maligna is extremely difficult to diagnose. Look at this one. There is nothing at all that could make you think of melanoma. There are no specific features, and there is not asymmetry. The opposite. The lesion is banal, symmetric, one color only. So obviously that's a difficult one, but today we have ways to deal with this kind of melanoma, the inverse approach, and so on. So let's say I would not include it anymore in the difficult to diagnose melanomas. As I said before, for me, the most difficult ones are the ones that deviate basic rules. For example, we know, and we have all agreed, and we all believe that blue clots are an extremely strong feature for the diagnosis of BCC. And in even if we see it again tomorrow, I think that I will conclude that this is most probably BCC. I don't know about you.
Yes.
My strong
Yes.
impression here is that it is a BCC. Of course, I'm not 100% sure because there is a large ulceration in the center, which does not allow us to see the entire lesion. But in the lower part, what is visible, the blue clots, the vessels that are visible, and the kind of pigmentation is the one that we know that fits with BCC much, much more. So this is a melanoma that for me is extremely difficult to diagnose. Of course, the good thing is that you think it's a BCC, therefore, at least you're going to excise it. Of course, not with the priority that you should, but at least you will excise it. So this is a subtype of difficult to diagnose melanomas. Again, another one that I don't need to convince anybody. We all know amelanotic melanoma is extremely difficult. Obviously, when it's early, when it's flat, it's even more difficult. Let me just show you two cases. You can see here the pattern. We only see vessels.
Clear cell acanthoma, easily.
Some of them are coiled, maybe. Some of them are dotted. By the way, this is not a melanoma. This is not a melanoma.
Bowens?
No. It's not the Bowens as it should be. It's a dermatofibroma. Dermatofibroma. Yeah, dermatofibroma might acquire many patterns, but this one is a melanoma. And look now in comparison, the two lesions together. So that's the melanoma, and look them side by side clinically, and side by side also dermatologically. In my view, there is a huge overlap.
Yes, but in this case, we have a problem of the false positive, which is the lesion on the left. You know what I mean? So very
course.
difficult to miss this melanoma because we excise both, and therefore,
Yeah. We excise both not because they are easy to diagnose, but because we have established and accepted rules to manage amelanotic lesions. Because obviously, I don't think that there is something specific in the image that could
Yeah.
make you believe that this is a melanoma. But thanks to the rule, this is a feasible melanoma to diagnose. Take a look at the next one. Clinically, what do you think? What would you say it should be?
Bowen's BCC.
BCC.
Owens or BCC. That's the close-up. That's dermoscopy. Maybe
Hyperpigmentation.
more to Bowen's now and less to BCC.
Yes.
Yeah.
Pink and brown, make me frown.
Yeah.
pink
So
and
it could be melanoma as well. Everything is possible. Not BCC, Bowen's or melanoma.
brown color is very suspicious.
Yeah, but
pink
I mean,
and brown.
yes, it's brown. It's suspicious, but also in Bowen's we might see brown color. It's not. It's
Yeah.
not. Okay. Second
What
case.
was it?
We will see all three together. Second case, quite similar, I think. Quite similar.
Yes. Again, Bowen.
Yeah.
Bowen dots in a line in the periphery.
Yeah, I would say that in both, Bowen is the most
Bowen.
likely diagnosis.
This is Bowen.
Yeah. And case number 3, again, quite similar.
Yeah.
This
So
could
now
be a
all
nothing.
together.
No, the third one could be a nothing to discard. If you ask me, first one could be a melanoma. Second one, Bowen's. Third one, whatever, I don't know.
Yeah.
First one, melanoma. Second one, Bowen's. And third one, Nevus.
Yeah.
But I would excise.
Whatever could be the correct.
LPLK.
LPLK, yeah. So the problem here would be if you consider that they are Bowen's, all of them, and you cryo.
No.
That's the point.
No,
and yesterday,
we will never cryo.
Exactly. And
when we are not sure about it.
Yesterday I had a live case that I was together with Konstantinos in front of my computer, and I showed him the moment that I received the report of a melanoma. I didn't find it now. Like these lesions here, looking a lot like a Bowen, that we, thank God, did not cryo, but we punched. So that's another example of a melanoma which mimics another tumor quite a lot, and this makes it very difficult to diagnose. To make you feel better, you were more or less correct. Only the first one is melanoma. Only the first one is melanoma.
Thank God.
Yeah, but a difficult melanoma in my view. Easy to miss. The second is Bowen's, of course.
Third one.
And the third one is one of my favorite tumors, not the number 1, but maybe the number 2, is a poroma.
Okay.
Poroma. We never think about it, yeah.
Then it's another difficult type of melanoma to diagnose, but as JP said here, it's not a problem because we have rules. We know that in any nodule that we are not sure about the diagnosis, we excise it immediately, and with this way, we can save ourselves from missing a melanoma like the one on the left, which is a thick melanoma. The one on the right is not a melanoma. It's a vascular tumor. It's an angioma, but you can see how similar they look both clinically and dermatoscopically. And imagine that, especially in a fast daily routine, that you might easily overlook something like this. It's impressive similarity. Obviously, a melanotic melanoma in general is difficult. but I will not spend time here because we have the rules. We know how to deal with amelanotic nodules, so everything is fine. And finally, I would like to close with this case, which was, in my view, one of the most difficult melanomas that we diagnosed. I will show you why. First of all, I don't know if you can see the age. The age is very young. It's like 25, something like this. And the lesion looks like this. So it's
pretty okay.
Looks like a nevus.
It's an obvious dermal nevus, and then something might be going on in the upper part that we have to check.
Yes.
And then dermatoscopically, it's this. So of course there is a dermal nevus, no question. The big one is the dermal nevus, and then the small one is not precisely the usual way that melanoma develops close to dermal nevi. And in fact, this was a nevoid melanoma developing in conjunction with a dermal nevus, unique case. And this nevoid melanoma is nevoid also clinically and dermatoscopically, in my view. Don't you think so?
Yes,
Yeah.
absolutely.
Yeah,
Yeah.
absolutely. This is a great example.
I mean, about the upper part, the lower part, the big is, of course, a dermal nevus, obviously. Okay. So it's not the usual way. What usually happens in dermal nevi is this. I mean, you see the dermal nevus and the melanoma, a junctional in situ melanoma growing peripherally. And this of these we have many. Again, dermal nevus and the junctional melanoma grow peripherally. Again, so many. But that case of nevoid melanoma I showed you was one of the most difficult melanomas I've ever seen. So now I think that we need to feel better. We need to feel better.
Yeah.
Great cases.
But why don't we go with the video? Did we stop for a moment the fluence? And we get a breath. Dermoscopy, it's a very nice small application for iPhone and Android in the field of dermoscopy. If you are a dermatologist, let's give a try. And if you are interested in dermoscopy and in diagnosing and preventing melanoma and non-melanoma skin cancer, you will find the app interesting to improve your skill and to have fun. Yeah, Dermoscopy app. You have to download. You didn't. Yeah, we are working hard. Yeah, to give more, let's say, levels of the game. Yeah.
Indeed. And I think that it was when did you establish it, Jeppy?
Oh, 2013, 12, 13.
You know, it was one of my first contacts with dermoscopy and seeing all these lesions and getting feedback. Probably it was the reason that, not the only reason, but it played a big role into being instigated into dermoscopy. I love this app.
But now that you say this, I remember that at the very beginning, with the first levels of dermoscopy, I realized something that later on we worked on this because it's like this. So I realized that when you know that you can play the levels multiple times, especially if you fail, you can play the levels multiple times. So I realized that I had the tendency to repeat precisely the same mistakes.
Always. I always make mistakes.
Even if I played after just 1 minute. So if I did not have 100% attention there, remember the case that I lost, I would lose again precisely the same. And I was not the only one. I realized that this happens to everybody. So in order to learn, you need something more. Than the simple feedback that it's wrong what is
like a poke, an electric shock. Mistake.
Yeah.
Okay.
Bene, Costantino, go.
Excellent. So You see the screen?
Yeah.
Excellent.
Yeah.
How to find melanomas. And so I want to go last now at this episode because I know that this would be a depressive episode, and I want to give as much as we can positive note.
Bravo.
Coming from the 11th World Congress of Melanoma, we had a great time. A big part of what we heard was that, okay, melanoma incidence keeps on increasing, but melanoma mortality dies. There's this entire discussion about overdiagnosis and how much we remove tumors and they may be overcalled as melanomas. But what I would like to share with everyone is that I prefer to excise 100 melanomas in situ and early invasive than miss 10 that can turn into this.
Yeah.
Like,
Of course.
Yeah.
or like this, which has also the blue-white veil that Emilia showed in the previous episode, that can be a bad prognostic factor.
But may I just interrupt you?
By all means.
To be honest, I do not feel not even 1% bad, not even 0.1% bad when I excise a melanoma in situ. I feel precisely the opposite.
I feel great. I feel great. But, there's a general sentiment that's like, oh, it's just a melanoma in situ. Yeah, but it's a melanoma in situ. So
I don't share this feeling at all, and I don't know any clinician that shares this feeling. I don't know personally anybody who does this job and understands that excising a melanoma in situ is a bad thing. In my view, all the clinicians all over the world, whenever they excise a melanoma in situ, they are happy, and in my opinion, they should be happy and proud, very satisfied.
Well,
Yeah.
of course,
Exactly.
everybody is, but maybe we have to give a little bit of the background why you bring this into the discussion, because there is a few people saying that come on, melanoma in situ is just nothing, you can leave it there. And this is a little bit the schizophrenic situation we are living today. In order to diminish overdiagnosis, we like to find ways to spare some excisions of melanoma in situ. No way. Let's excise all of them. All of them.
it's exactly my point, and it's exactly where I'm
Yeah.
going. So this is a 2 millimeter lesion. Do you have any doubt that this is the start of a melanoma?
Yeah.
This is a
This is
melanoma
a
in situ.
melanoma.
This is a melanoma in situ. Is it hard to find?
Mhm.
If you look at the patient, no, it's not that hard to find. Is there a problem if we excise this? It's 2 millimeters. If you do a 5 millimeter excision, it's done. You have nothing to do
Yeah.
afterwards. Are we sure that it will turn into these aggressive melanomas? No. But who
No.
cares?
Who cares?
Who cares?
Unless somebody is sure that it will not. If somebody is sure that it will not, then we could discuss it.
Okay, if you can back it up with evidence that this will not, I'm more than fine
Then okay.
to leave it there.
Yeah.
Here again, this is a melanoma in situ, regressive. Why leave it there? And indeed, I go to the first paper talking about the limitations of dermoscopy in the recognition of melanoma by Harald Hitler, where they actually compared dermoscopic features of melanocytic nevi and those of early melanomas. And they found that dermoscopy depends on the appearance of classic dermoscopic features and therefore limited in the diagnosis of very early and mainly featureless melanomas. Sorry, are you worried about these lesions?
Not
The
particularly.
upper a little bit, the lower.
Not particularly, but that's why we do follow-up. And yes, they changed, they evolved, and they caught them at the stage of melanoma in situ. And that's okay.
Yeah.
That's okay. And I want to highlight that, yes, of course, today we're doing an unhappy hour. So discussing about difficult to find melanomas. But this is literally my last Wednesday in my hospital, in my clinic, seeing the patients, the outpatients that were sent to us for evaluation of lesions. So all the melanocytic lesions that I sent for excision as suspicious for melanoma, they're consecutive. I showed them to Emilia the other day. So this is one. Okay. Do you have a doubt that this is suspicious for melanoma?
No.
For sure.
Melanoma. Second one, 50-year-old with this lesion. Could it be spitz nevus? Okay. If you send it for excision,
Yeah.
most likely it will be a melanoma. Third one,
Melanoma in situ.
doubt? Melanoma in situ.
Inside.
Melanoma in situ. Fourth one,
Melanoma.
all
No.
in the same day, all consecutive.
Yeah.
Oh,
An ugly one.
2.4 millimeters. 2.4.
I will come back with the biopsy. These were literally 4 days ago. Fifth patient,
Inside.
inside. Fifth patient,
Microinvasive.
microinvasive.
0.3.
I said 0.4. I will come back to see. Another one, more tricky. It looks a bit like a sub-K, but is there a problem if we excise this?
No.
No.
None whatsoever.
It's also going to be invasive.
Yeah.
Micro.
There's
Micro.
follicular obliteration. 0.1.
Last patient, and these are 7 patients within the same day. Okay, we have in doubt.
No.
0.9.
The same patient also had this lesion. Yes,
Inside.
this most likely is a melanoma in situ. Could we have missed it? Yes. But if we do a proper skin check, most likely we will not. It is more hard, but we can get it. And here I want to go back to what Zepi has published, and I really love this paper. Let me share my entire screen. So, yes, there are some difficult diagnosed melanomas, but if we take into account, and this is from our beautiful journal DPC, the patient's age. So this lesion on a child most likely will be a spitz nevus. This lesion on an 80-year-old most likely will be a melanoma. The location, the sex, along with the location, the comparison, so a lesion deviating from everything else, and additionally, what is the fifth rule? Where's the fifth rule?
Nodular.
Nodular.
Palpable and or pink lesions. If we take all these things into account, the possibilities of us missing a clear melanoma are small. And you know what? Yes, and this is why this blank slide is here. The melanomas that we miss, we've never photographed. We never knew they were there. And is that okay? Most likely it is, because if you see 20 patients a day, or 30 patients, or 40 patients, especially high risk, you may do a mistake. And is that okay? You know what? It is. Some things are very hard to find. Do we have all these rules? And do we do all this work in order to try to diminish these cases? Yes. And most likely, we lose a very small proportion of melanomas. And I wanted to come back to what you showed, Jeppe, before. This patient with a lesion on the back, the very nevoid one. This is a patient that is always stuck in my mind. I found on him on the same day 2 melanomas. One was 0.3, the other one was 0.7. And he said to me, "Doctor, I also have a lesion here at the belt zone that occasionally kind of bleeds and everything." It was a nevoid melanoma. It looked to me like a nevoid.
I remember your story. You didn't take the photo.
I never took the photo. Thankfully, when he went to the surgeon to take out the other 2 melanomas, the surgeon took also that because the patient complained, this bleeds, take it out. And that was the deepest of them. It was a 2.3 nevoid melanoma. I don't have the picture. And this is something to remember. Yes, we can do mistakes.
Yes, these
Thankfully,
Nevoid melanomas are really very challenging.
thankfully, the patient was complained to the surgeon, and the surgeon was kind enough to take that along with the other two together.
Yeah.
And these are because we don't do everything correct, and these are two mistakes that I have done. Are you concerned by the lesion clinically?
I completely agree with you. And sometimes, especially the ones looking like dermal nevus, we are so sure about that. Oh, that's normal. But I think we have to look at every lesion, every lesion. Even we are sure about that it's the dermal nevus.
Exactly. So are you concerned about this lesion?
Yeah, now yes.
Now, yes.
Yes.
So you know what I did? I told him to see him after 4 months, 3 months, like a short-term monitoring. Because I don't know why. It maybe depended on the mood. Like
Yeah.
at the moment, I didn't feel that this was worrisome. Or I was a bit worried, but not enough to take it out immediately.
Yeah.
And he came 3 months after, and of course there's a change. And this was a 0.4 millimeter melanoma. But still, it was a 0.4 millimeter melanoma. If you're on alert, you can always minimize the risk of losing a melanoma. And I finish with this case. I've shown it 100 times. I will show it for the 101st because it's always a reminder. This is clinical, this is dermoscopic. Would you think that this is a melanoma?
Way.
Yes. Breast of thickness 9 millimeter. I remember this one.
Exactly, exactly. So keep in mind the rules. A melanotic nodule, growing, excise. This was a Breslow thickness 9 millimeter melanoma. Totally, like it's a yellow melanoma.
Yeah, but Kostas, for this one, and we could show many, we should not be scared anymore because we have a clear-cut rule which works very well. I mean, nobody would dismiss, would ignore, would overlook a lesion like this because it's a nodule. We do not have a specific diagnosis. Therefore, we know that we should excise it. Also, to me, it looks like a squamous cell mainly, but it's fine. It's fine.
Emilios, I remember you had a case of desmoplastic melanoma on the scalp, and it was just flat, and breast of thickness was 7 point something like that.
Correct.
But it was just pink structureless, some white lines maybe.
Correct.
I never forget that case. It was very educative. Do you have the photo? Maybe you can show it. It was really very hard to diagnose melanoma with a very thick breast lobe.
But what I want to highlight with this presentation is that yes, there are melanomas that we will miss, but we're doing a quite good job. And I think that we should be happy with ourselves the way the specialty has evolved, especially in this field.
But you know that there is a way not to miss melanomas.
Excise everything?
Oh, even if you excise everything, still you will miss melanoma. There is another way.
What is it? Not practice.
Yeah. Don't visit patients.
Yeah.
Don't visit patients.
The only way to not miss
Something else.
is to not see patients. If you see and you do, of course you will miss something. Use the rules, use common sense, and see the patient back. I think this is the clue. Bring them back.
We have a couple of comments and questions. One of them says,
I like very much this question. What ratio benign to melanoma is healthy? This is very good. Yeah. What is LT? How many benign lesions we should excise to find a melanoma? Let's say 100 benign lesions for each melanoma is too much.
Yes.
Let's say so. Generally speaking, in the world, we could say that 30 is the maximum. But if you work in this specific field, you can go less than 10. Yeah, so let's say 10 benign to 1 melanoma is a very healthy.
There is a study about that,
Yeah.
actually, showing that people that work in the field excise 9 to 10 benign lesions for one melanoma, and experts excise approximately 3 to 3.5 for one melanoma.
Yeah, but if I may say something, my answer to this question is that since you care about this question, then I am sure that your number needed to excise is perfect, and it's gonna be better and better with experience. So you are not among the ones that will have a bad ratio. The ones that have a bad ratio are the ones that don't care at all about you, about what you care.
Yeah.
They don't care. It's not their interest. These are ones with a 100 to 1 ratio that we never improved, of course.
I agree.
Question, which by the way might be a topic for one of the next episodes. How can we determine dermatoscopically if a lesion is suspicious to be invasive or not? Because people hear us often do predictions of breast lobe thickness, say, oh, this is inside, oh, this should be 0.7, oh, this should be 1, and maybe we could devote an episode to discuss what we know about dermoscopy for predicting invasiveness and for predicting breast lobe thickness. There are 2 questions on this.
Absolutely. And actually, yesterday, I received many questions on that. This would be an excellent topic. It's our next topic. I love it.
Yeah.
Is it okay to perform incisional biopsy to a large pigmented lesion of the scalp with a clinical diagnosis of melanoma? Of course, yes. Any kind of biopsy, it's absolutely okay.
Try to get the thickest part first. That's the only thing.
Yeah.
Yeah, but even if not, then you're going to excise it anyhow. The way to end the melanoma epidemic is to end the epidemic of diagnosis of melanoma, cited on one of the presentations from the last AAD. Yes, I know. Is it correct to report melanoma in situ as melanoma from an epidemiologic point of view? That's a very valid discussion, which, however, is clinically irrelevant in my opinion. It's epidemiologically only relevant. And maybe if we reported all melanomas in situ with a different name, even melanomas 1A with a different term, as has been suggested recently, it was suggested that we call them melanocytic neoplasms of low malignant potential.
Potential, yeah.
Of course, this could correct the epidemiologic curves concerning incidence, and for me, that would be absolutely fine. That's not a problem. We can call them in whichever way we like to call them.
Can I ask you something? Do you care?
Not at all, not at all.
Not at all.
The crucial thing is that these lesions, until the moment that we will have robust evidence on which lesion has the potential to metastasize and which does not, until that moment, these lesions, to my understanding, should be excised because this is the best service we can offer to our patients and the safest. Now, if you want to call them in a different way, that's absolutely fine.
It's written literally in the NCCN guidelines. The mainstay of treatment of melanoma is excision of the tumor. Take it out if it comes as heavily dysplastic nevus, or melanoma in situ, or melanoma 0.2. Yay, I have done a good service to my patient. Done.
30%.
Absolutely agree with you, Konstantinos. After the Congress, at least we are on the same ship.
35% of melanomas will never become invasive, but if you scan people every 6 months, only 11.5 will go beyond MIS, beyond in situ. I don't know about the numbers, Red, that you mentioned, if they are precise.
I don't know them.
But the logic makes sense.
But if it has the paper, please send it to us. I would love to read it.
Yeah. In case of an ulcerated lesion resembling BCC, what is the recommended excision margin? 1-2 millimeters or 4 millimeters? Well, I mean, the narrow excision, clinically healthy margins, this means usually 2 to 3 millimeters. And I think we got almost everything. If you ask about an ideal number needed to excise, then you should also indicate an acceptable number of missed melanomas, because the number needed to excise depends on this last figure. I don't think we can indicate an acceptable number of missed melanomas. The goal would be that this number should be 0, but since we are humans and not superhumans, we cannot have 0. But with all these tools that we have today, we can be quite closer to 0 than what we were in the past, I think. What about medical legal aspects when you miss nevoid melanoma? Well,
Very difficult.
yeah,
Very difficult to assess.
yeah,
Yeah,
very
but
difficult.
the thing is that medical legally, if you call 10 experts, they will say that they will attest under oath that this is the most hard melanoma to diagnose. So, yes, of course, it's a tragedy when it happens, but it's something that happens. And not only are we not machines, the machines will fail as well. Is there a better? There's no gold standard. We are the gold standard, dermatologists. So we will do mistakes. Hopefully, by training and expertise, they will be as least as possible, but they will still be there.
Yeah.
I think we got all the questions, guys. I have to
Oh,
take.
video. Sebino, video.
Would you like to take high-resolution pictures of a lesion? High optical resolution and visibility of the smallest structures can be reached with the HiNet SLR SLM camera adapters. The HiNet SLR SLM camera adapter allows best optical quality and image resolution. The SLR SLM adapter flow allows the smoothest workflow integration and is easy to use. This video will show you how to attach the HiNet SLR SLM camera adapter flow to your camera. You need your HiNet dermatoscope, a digital camera, a fixed focal length lens, and the camera adapter flow. To find the right combination of camera, lens, and camera adapter, please have a look at our recommendations in the how-to document linked below. For the assembly, screw the camera adapter flow onto the lens filter and then attach the fixed focal length lens to your digital camera. With the dermatoscope detached, you can still take overview images. Before you connect your HiNet dermatoscope, turn the focusing ring until the middle line of the scale is visible to get a sharp image. With the adapter carefully to the dermatoscope, otherwise the camera's autofocus can get blocked. On your dermatoscope, and you are ready to take dermatoscopic images. Find out what's best for you. Have a look at hinet.com/adapters.
Very nice, very nice. Very good system of image capturing. Remember also the importance of the good clinical images for many reasons. It's not only dermoscopy. And that's a very nice system that you can combine both. And now, my friends, we go to see what Penelope has prepared for
Penelope.
us tonight.
Guys, by the way, sorry, but have you noticed what Zoom does? If I do like this, it follows.
It follows. Yeah.
Isn't it great? It's like AI at its best.
No, but this is maybe because you are on an iPad.
No, I'm on my MacBook.
Ah.
If I do like this, it adjusts. If I do like this, it also adjusts. It zooms in. It's crazy.
Nice.
Yeah, I love it.
Fantastico. Nisa, are you ready for... that's an entity I love.
I love it.
recently, that I don't know how many years ago, I didn't know about this entity, and I think I first heard it from JP, if I'm not wrong.
Hypokeratosis.
Yes.
Hypokeratotic circumscribed.
Yeah.
That
Well,
one.
with
acral
say
hypokeratotic circumscribed, something like that. I always forget the exact complete name.
star-like scales at the periphery.
Acral hypokeratotic circumscribed.
Lisa,
Acquire
acral something benign.
Yeah.
yeah. And dotted vessels, circumscribed palmar hypokeratosis. Nice. Then lagoons. Nice, beautiful.
This entity is very common in patients with xeroderma pigmentosum. Have you ever recognized this? I have 3 patients with XP and they all have this.
Really?
Really, it's very interesting.
I remember finding it on one. You're right. Okay.
Vascular.
Also, but is it lymphangioma? Because do I see some?
The same, because the lacunas have this shape that they have also in lymphoma. Well, in the end, I think it's an angioma, typical red, small,
Angioma serpiginosum. Angioma serpiginosum.
superficial dermis.
Yeah.
The serpiginosum angioma. Then, sad case.
Yeah. Very sad. Yeah.
Angiosarcoma.
8-year-old medical history of recurrent breast cancer, extensive deuterated erythematous plaque for 1 year on the tempofrontal region. You see dermoscopy, a lot of vessels,
Metastasis.
color corresponding to the dense infiltrate that exists there. Of course, a broad differential. Eventually, that was something not so common, but not so rare on the other hand. Metastasis.
Yeah.
Metastasis.
breast cancer metastasize very often on the scalp.
Neck. Yeah.
Yeah.
Okay. And now at the very bad moment, my computer decided to collapse. Do you still hear me?
Yes.
Yes.
See me? I didn't close my
We
camera.
can see you.
But
We can see.
You can see me also. Okay.
breast
No.
cancer.
Just
Breast
continue, Emilios. We can see you.
What ακύρωση, ρε?
No, it doesn't work. I know what I'm doing. It doesn't know. Yeah, what the sorry. Come on now.
That's okay, continue, we can say.
The arrow works. Okay, so I don't see much, I have to tell you, so you have to describe what we see.
No, but it's great because this tab is exactly on the lesion. Like everywhere. It's on the lesion.
Okay.
It's an hemorrhagic crust or pigmentation. We cannot see.
Yeah, we did it.
Great.
Now it's okay.
Yeah.
Yeah.
New pigmented lesion on the bald scalp. Yeah.
This is seborrheic keratosis. Come on.
Keratosis. This is seborrheic keratosis. This should be.
It was a seborrheic keratosis, but it's not. It's
Please
not.
see.
It's not a seborrheic keratosis. Although
It's a nodular one. So.
And it is eventually, there are some scales, there are the hairpin vessels that point towards keratinization. So if it's not a keratosis, then it's the other keratinizing tumor, which is a
Bowens.
Bowens.
Yeah, pigmented Bowens.
Wonderful. And for Sebastiano on the hand, 54, new eroded erythematous lesion on the back of his hand. Sebi, looks like...
Probably BCC.
I guess it should be BCC, but this pigmented ulcerated nodular BCC in an unusual location.
Very unusual.
Bravo,
Pascal.
Bravo.
Thank you.
Bene. Sebi, you appeared very. I mean, Sebi is very missing in this episode. Yeah, Sebi, what's going on? Are you okay?
Yeah, all it's okay. I am following the lesson, the episode.
Bravo, bravo,
He's full
bravo.
charisma.
Yeah.
Our handsome Sebi.
Thank
Yeah,
you.
careless Sebi. Very good.
Do you have access to the Kahoot?
Let's go.
Now you don't
Murphy, I didn't say hairless. I just said handsome, please.
you don't hear me, I guess, do you? No.
Yes, we do.
Yes, we do.
Konstantinos, do you have access to the Kahoot?
Yes.
Go, because I cannot do anything in my computer.
1 second.
Emilio, what's going on with your computer?
I told him he needs a new one.
You are overstressing your computer.
Probably. Remember when you share your screen to share sound. Box that says share
Yes.
sound.
There was a problem with the mouse last week, Emilios?
No, that's another problem now. It's not the mouse. So Kahoot, my friends. By the way, until Konstantinos prepares the Kahoot, we have to remind the people that for the next 2 consecutive Sundays, there will be no happy hour because of the we're gonna do a break for the Easter.
Easter break.
Look at that.
Easter break.
Look at that common faces from down.
So we will be back on the April the 27th.
27.
Do you see my screen?
Yeah.
Excellent. Can you hear the sound as well?
Again, bravo. Wonderful. Blue girl. Show.
Joanna.
Oh, wow. He's like,
So let's play the game. Jeppy, predict the country of the winner.
Turkey.
Turkey, again, you go with a safe choice. Nisa?
Winner.
What?
Winner. There was a nickname called Winner. I support
which country will be the winner?
Country.
Turkey for sure.
Votes for Turkey.
Votes for Turkey.
I go for Italy.
You go for Italy.
Okay, then I go for Greece.
I like it. So,
Go.
let's go.
Where's Laura? If she plays, I'm gonna support Italy. Laura.
Okay, so here we have 54 years old, husband and wife, male 54, female 52.
Okay.
I'm guessing we're talking about this lesion and this lesion, of course.
Click next. Yeah.
These are the close-ups.
Mm-hmm.
And this is the dermoscopy.
Mm-hmm.
Mm-hmm.
When melanomas, diagnosis.
Basta with melanoma. Come on. Basta with melanoma.
A nevus, B melanoma. A melanoma, B nevus. A melanoma, B melanoma.
Hey, come on. Very pessimistic.
I think this will be a
68.
hard
Sorry.
debut.
Really?
Basta melanoma. Basta.
So you could ask now why we excite them, but I don't know.
Yeah.
The first one looks okay. The second one could be a nested melanoma. So
There are
Oh,
hello.
EV is on the lead. Then D nevus. Then Dada and Sheriff. Sisters. So we have twins, like we have doubles. This time, Emilios.
Yeah. Well, not all.
Two sisters. The one is 44 years old. The second one is 46 years old. We're talking about this lesion on the arm. This is the clinical close-up, and this is dermoscopy.
Okay.
Diagnosis. Nevus nevus, nevus melanoma, melanoma nevus, or melanoma melanoma. Guys, there are so many people playing. 190, 200 people are playing.
52.
Melanoma nevus, 52.
News. Bravo.
Bene.
52 right answer.
And if we look at the lesions, this one looks indeed like a melanoma, probably developing on a nevus. We have the negative network, whereas here it's a combined nevus, Emilios.
It's a blue with junction.
Yeah. And Pippo is on the lead. Pippo, Italy. Pippo.
Pippo.
Oggi,
Pippo.
Tam, and D nevus. Here, a lesion on the scalp of a 64-year-old male. Female.
5-year-old lady, but it's okay. Doesn't really matter.
So this is the dermoscopy. And true or false, this is simply a sub-K.
Yes.
Who prepares this Kahoot? Emilios or Konstantinos?
Emilios.
False.
And what's the diagnosis, Jeppy?
What is
BCC.
D.
BC.
BCC.
Huh?
Yeah, BCC.
BCC.
Pippo is still on the lead. Then we have D nevus, then Oggi, Utam, and Brutal.
Brutal.
Moving forward, this is a 58-year-old male with this lesion on the scalp, and also he hit his head.
Very ugly.
This is clinical.
Very ugly. Let me tell you. I can't.
This is dermoscopy.
Yeah.
Diagnosis. Combined nevus, sub-K, nevus and BC, or a melanoma.
I vote for Nevus and BCC.
You're very optimistic today, Jeffy.
Very good.
Of course. Bravo.
Okay, Jeffy, Breslow.
0.9.
Nisa?
0.7.
I also go for 0.7. Emilios, what was it?
If I'm not wrong, 0.6.
Okay, good.
I remember.
So D nevus is on the lead. Then Oggi, Pippo, Mancinelli, and Utam. Is this the last case, Emilio?
Yeah.
Last case.
Yes.
Last case.
So excited.
We're talking about this lesion. Clinical close-up and dermoscopy.
Yeah. Wonderful.
Quiz. What is your diagnosis? Combined nevus, sub-K, nevus NBC, or a melanoma?
Oh.
Oh,
Wow, great.
Is almost impossible here. Yeah.
yes.
But
That was a
I was
hard
thinking
one.
combined nevus here.
Uh,
This was my vote as well.
no, I was going for sub K, to be honest. So let's see
Combined.
the leaderboard.
Podium.
Number 3,
Oh.
Pipo.
People.
Number 2, Oggi.
Okay.
G and
Number
D
1,
nevus.
D
D
nevus.
nevus.
Hebrews.
Bravo.
Wow.
But there's no Turkish.
They
D.
are Turkish.
See who is
You
D.
think Nivus is not Turkish? Really?
No.
You get sent
Who
from
is
the
Dinivus? Dinivus.
Diana.
Diana from Romania.
Uh,
I think she
Brava,
previously got it. I
Diana.
remember Diana
Diana.
from Romania.
Romania. One.
Second one is Turkish, unfortunately. You
Brava, Diana.
Congratulations. Congratulations.
Diana.
obviously the
Congratulations.
second place is Turkish.
Yeah.
I don't know if you can hear me.
Yes,
Yes.
absolutely, Diana.
Okay.
Hello.
I'm sorry, I don't have my camera is a bit broken.
No problem whatsoever. Congratulations.
How do you feel?
Yeah, last year you got it, if I remember correctly. Is it true?
No, it's the first time I'm winning.
Okay.
Yes, but
Congratulations.
last time I was on second or third place. I don't remember exactly.
Perfect.
So how do you feel that you won in the happy hour?
Sorry.
Great. We have to make a party of the winners of the
Oh,
Kaut
yay!
Tower. Definitely.
That would be great.
Ragazzi, so remember, no next Sunday, no following Sunday, but 27 of April we are back. Ragazzi, un bacione. I love you so much.
Bacione e abbraccione.
Great.
We love you more. We love you more, Jeppi.
Love me more or less than yesterday?
Much more.
Much more.
Much more. Much.
Much more than yesterday and much less than tomorrow.
Thank you so much.
Bye bye.
Buonanotte.
Ciao ragazzi. See you in a few.
Bye.
Happy Easter to everyone.
Happy Easter to you.